Hey, Andrew Wolf here. In this video, I'm going to talk about the control of hemostasis. Now, remember, I have here in front of me a picture of the intrinsic pathway and the extrinsic pathway. And just for by way of review, with the intrinsic pathway, it begins with injury from endothelial injury, which allows collagen um, to become in contact with Hageman factor. Hageman factor is activated into activate an activated form. The Hageman factor activates factor 11 to 11A changes, and then that changes factor 9 to 9A, and 9A activates 10 to become factor 10A, and factor 10A causes prothrombin to become thrombin, and thrombin is a proteolytic enzyme that breaks down fibrinogen into fibrin, and fibrin is are long-stranded proteins that are able to actively bind together to form a polymer. Then the polymer is then connected together by cross bridges due to activated factor 13A. So we end up with these cross bridges here, and that is our clot. Okay, now the extrinsic pathway starts with tissue trauma or vessel disruption or inflammation. Remember, there's three factors that can cause tissue factor to turn into its activated form, which is factor 3 to turn into its activated form, factor 3A. That causes factor 7 to turn into its active form, factor 7A. Factor 7A then causes 10 to 10A, prothrombin to thrombin, and fibrinogen to fibrin. So everything from factor 10 down is called the common pathway, because whether it's starting from the extrinsic pathway or intrinsic pathway, once we activate once we activate factor 10 to factor 10A, then the pathways are the same. Okay. Now remember, when I talked about the pathways, I talked about how they are systems of amplification, because at each level we have more proteins involved. So here, we may start off with 100 proteins. When we get down here, we have 1,000 proteins, and then we have 10,000 proteins, then we have 100,000 proteins, a million proteins, and 10 million proteins. And that's just an example. I don't know whether it's a factor of 10 at each step, but it is a factor of something where it's amplified from step to step. Now, that is very effective in causing hemostasis even in severe injuries, but it is a very dangerous situation, because you can end up with pathophysiology if we have a amplified system that has run amok and is not controlled. If we lose control of the system, we end up with a pathophysiology called DIC, or disseminated intravascular coagulation. And for those of you who have experienced it, what you end up with is clotting all over the body and microvasculature. So you end up with emboli and thrombi all over the body. And then clotting factors are completely used up, and then you end up with bleeding because you've exhausted all clotting factors. Okay, so just to give you an example of how if this amplified system is not controlled, you can quickly get to a state where you are clotting all over the body, and then you completely exhaust your clotting factors. You've clotted as much as you can, and then you begin to bleed. So let's talk about the control systems. Okay, so there's two basic control systems in our coagulation system, and the first is negative feedback, and the second is fibrin clot degradation. or breakdown. Okay, now negative feedback. There are actually sort of two subsystems here. Actually, there's three or four, but I'm only going to talk about two. One is the antithrombin system, and this is based on a protein called antithrombin 3. Okay, so the way that antithrombin 3 works is it's a negative feedback loop where thrombin stimulates antithrombin 3 and antithrombin 3 blocks the formation of factor 10A, and it also blocks the formation of thrombin. So it works in two areas. So the more thrombin that there is, the more active antithrombin 3 is, and it will block clotting in both by preventing the creation of factor 10A and by directly preventing the creation of thrombin. Now, antithrombin 3 is very interesting because we actually use it in medicine, because we use heparin to stimulate antithrombin 3. So heparin initiates antithrombin 3, and it is by this mechanism that heparin works as an anticoagulant, because it blocks the formation of factor 10A and it blocks the formation of thrombin. And interestingly enough, there are patients that are not responsive to heparin. So if you ever have a patient that is on a IV heparin drip and you are checking their partial thromboplastin time, their PTT, and no matter how much heparin you give them, their PTT is not increasing, because and that is because we actually may have an antithrombin 3 deficit. So no matter how much heparin you give them, there's just no antithrombin 3 to activate. So one thing that you can do if you have a patient that has a stubbornly low partial thromboplastin time, no matter how much heparin you give them, is you can test an antithrombin 3 level, and you may find that it's very low. So ironically, if you give them antithrombin 3, then they will actually begin to respond to heparin, and it will block clotting. Okay, so that gives you an example of antithrombin 3. Now, another protein that is important in the negative feedback is protein C. Protein C is also activated by thrombin, and it also blocks prothrombin from becoming thrombin. So this is protein C. Okay, and it does. There's a few other things that it does, but I don't want to get into a complicated discussion. There's a few other factors that it affects, but its major effect is by blocking prothrombin from becoming thrombin. There's also a protein called protein S that has a very similar effect, and is also stimulated by thrombin. Now, interestingly enough, if you have a patient that has thromboembolic disease that is getting DVTs, there are a bunch of tests that we will check to see why they have this procoagulant condition, and it is actually fairly common to have a deficiency of protein S. So we have a deficient negative feedback system that is keeping clotting from getting out of control. Okay, so those are the negative feedback systems, and then we also have the fibrin clot degradation system. Now, the fibrin clot degradation system is centered around a protein called plasminogen. Now, plasminogen becomes activated to plasmin, and Plasmin is a protease that breaks down fibrin clots. So it starts to break them up into little pieces. And actually you can detect the little pieces. You end up with small little pieces of what were fibrin clots, and these are called fibrin degradation products. And we actually have labs that look for these, and that just tells us how active plasmin is. So plasmin breaks down the linked fibrin and thereby breaks down existing clots. Okay, there are two things that can cause the inactive plasminogen protein to become plasmin. One is thrombin. So again, we have another negative feedback loop system here. And then the other is a protein many of you have heard of called tissue plasminogen activator. So otherwise known as TPA. And you probably have heard of this because this is actually a protein that we have figured out how to create, and we use it clinically to break up clots. We used to use it very commonly for clots in the coronary arteries. We also use it if a patient presents with an ischemic stroke, an ischemic stroke that is new enough to benefit from clot dissolution. So tissue plasminogen activator is actually activated by endothelial cells in natural and by other tissue cells in the body to break down clots. And again, the way that it does that is by causing plasminogen to be transformed into plasmin, and plasmin is a protease that breaks down fibrin. Okay, so that is all that I have for this video. Please take a moment to give me some feedback, and if you'd like to see more videos on the hematologic system, you can check out my channel for quick and easy access. Thank you.